glad that I'm able to be on after, what is it, about a couple of months now of not being able to be on because of being on inpatient. But hi, everyone. I'm Drew. I'm a PGY1 in Med Peds at WMed. Still awaiting them to make the decision on whether or not they are going to participate in global VMR and start recruiting IMGs. But interviews are already going, so who knows? It might be better late than never, though. But this is a case that sort of is on the border between medicine and pediatrics, but I think it'll be a good one for everyone. So let's get started, shall we?
Sounds great, Drew. And again, everybody who is joining, please feel free to share your thoughts in the chat. And I may also call on individuals to share their thinking out loud after you share some things in the chat. But the hope is that this will really just become a one big problem-solving case session here.
All right. So chief concern for this patient is dyspnea and chest pain. I'm going to stop there for now. I want to get everybody's thoughts in the chat before I go into this case. And I also want to ask the question, what different things would you think about if you knew that this case was about a patient who is a young adult rather than an older adult?
All right, so it sounds like we're dealing with dyspnea and chest pain in a younger adult. So I would love to see, so I'm seeing Catherine highlighting spontaneous pneumothorax.
Ooh, fun, actually.
Lung issue, pleural issue, pericardial issue.
Yeah. For those people who are saying pneumothorax, that's prescient. Not necessarily the thing I was thinking about, but okay.
Ceoyan, maybe I can come to you to share some of your thoughts here. I apologize if I mispronounced your name, but it would be great to hear your thoughts here, sort of highlighting lung, pleural, pericardial disease. And I think it's a great anatomic differential to start things off.
Hi. I actually don't really have much to share about, because I'm a medical student. I don't really have good pearls or anything, but I was just thinking anatomically inside of the chest cavity with this sort of non-specific presentation or chief complaint. So because if this is a young patient, so I was first think heart and then the lungs and then the pleura and the pericardium, but then if it's a younger patient, then it's probably not cardiovascular causing or the coronary vessels type of picture. So I was thinking more of the other three. Yeah.
You mentioned at the beginning that you feel like you didn't have any pearls, and I would say that you just gave us a phenomenal list of pearls there, which is saying that of the causes of chest pain, the ones that are most likely to localize to a process that causes dyspnea are things that are going to localize into the cardiac or into the pulmonary disease systems. You took all comers, right? If we take all comers who are older adults, the priority when we're thinking about cardiac disease manifesting with chest pain is related to atherosclerotic coronary artery disease. But you said, wait a second, that seems unlikely here in somebody who is going to be a younger adult. So you're thinking about inflammation of the tissues in and around the heart and the lungs, or potentially something else happening that's unrelated to one of these more common aging diseases like coronary artery disease. I see Rohan mentioning skin in our anatomical differential diagnosis. Rohan, do you mind if I come to you to share a little bit more about what you're thinking there?
Yeah, just being comprehensive, I think musculoskeletal, cardiac, and respiratory systems seem like the most likely to be involved here, but certainly a patient with chest pain, you should look at them and make sure there's no rash. You could have something like a zoster infection. I had a patient who was HIV positive that had disseminated zoster and had some pretty gnarly chest pain, so definitely a possibility.
Yeah, or an immunocompetent, stressed out college freshman, as I mentioned in the chat.
Yes, indeed, indeed. Well, I think that this is an absolutely fantastic discussion so far, but I really want to say, Zayon, am I pronouncing your name correctly? Do you mind, just because I'm going to refer to your thoughts multiple times here over these next couple minutes. I just want to make sure I pronounce your name correct.
It's actually Soyeon, but it's a difficult name to pronounce.
Zayon.
Mhm.
Thank you so much. And where are you joining us from today?
I'm in Shanghai, China, but I'm a South Korean.
Awesome. Well, thank you so much for being here. I just wanted to I want to sort of build off of the points that you made here, which is that when we think about, if we were to take these two chief concerns together and think about holding them up next to one another, right? Chest pain and dyspnea are both two primary chief concerns within the world of the internal medicine physician, and it also seems like within the med peds physician as well, given that Drew is bringing us this case. We oftentimes frame or ask ourselves, which of these chief concerns are we going to prioritize based off of the severity of the chief concern, but also how narrow the differential diagnosis is. Dyspnea, we've talked about before, is usually going to localize to either the pulmonary system, the cardiac system, or somewhere else, like the vasculature or the neuromuscular system. Chest pain, similarly, can be related to those same areas: the heart, the lungs, the esophagus, the musculoskeletal system, or the skin, as Rohan mentioned. So if we take those two lists side by side and say where potentially is the overlap in these two chief concerns, we are localizing both of them to what is going to be the two most prominent organ systems based on the base rate alone, which is going to be the heart and the lungs. Now, we can certainly use the esophagus to give us chest pain and dyspnea. For example, if somebody has an esophageal rupture, that will oftentimes leak its way over into the mediastinal space and cause mediastinitis. If somebody has something like achalasia and ends up aspirating food, then we can certainly get chest pain and a pulmonary problem in that regard. But just based off of the base rate alone, these two chief concerns together prioritize a cardiac process or a pulmonary process. When we're thinking about which of these is more likely, we then have to turn our attention to what the associated symptoms are. If there is a syndrome of systemic inflammation, the priority of lung disease goes up. And that's because most pulmonary processes that will happen acutely will usually be related to acute inflammation in the lungs. You can think of pneumonia. If there is potentially a component of cardiac disease here, then we will usually see the dyspnea and chest pain manifest with signs and symptoms of volume overload, right? Things like lower extremity edema, orthopnea, paroxysmal nocturnal dyspnea, and weight gain. And so as we hear the HPI from Drew, what I'm going to be looking for is saying, is there a syndrome of systemic inflammation? Volume overload that I'm hearing. There's a chance that we're going to hear neither. And then there's also a chance we're going to hear cardiac diseases that may exist. But I think at this point, where we are going to prioritize our cognitive energy is going to be saying, is this something that's localizing to the lungs, the heart, both, or somewhere else? And we can use some of the associated symptoms like systemic inflammation or the presence of volume overload to help paint a clearer picture of where this disease process is. There's a chance that we're going to move our way out of the thoracic cavity and into the areas that Rohan mentioned, like the lungs and the skin. And then if we think about the list of diseases that we're thinking about, as Soyeon mentioned, we are going to be thinking less about some of the common diseases of aging, like coronary atherosclerosis or maybe chronic obstructive lung disease, and thinking more about diseases that are going to affect a younger adult, whether those are connected, whether those are vascular diseases. I saw potential vascular processes make their way into the chat, or thinking about diseases that may be a manifestation of underlying immunocompromise, as Rohan mentioned, whether that's something that localizes to the skin or something that localizes to the visceral organs as well. So Drew, why don't you go ahead and give us the rest of the background history, and then we can kind of see how this picture continues to take shape.
Okay. So hopefully, given that this is a young adult case and sort of on the border between pediatrics and young adults, the rest of you are not as scared. I know Rowan is applying med peds as well this year. So, but this is an 18-year-old gentleman whose big bit of history is that he has asthma that is poorly controlled and has had multiple previous hospitalizations, who, as I mentioned before, presented with dyspnea and chest pain. 2 days prior to admission, the patient woke up with shortness of breath and then some mild chest pain. And then the day prior to admission, the shortness of breath began worsening, and the patient's father noticed that he was increasingly pale, he had difficulty breathing, and his fingers were cyanotic. The dad basically put a pulse ox on him and found that his O2 sats were around 94%, and this patient typically sats in the upper 90s. He's tried albuterol nebulizers every 2 to 3 hours with some symptomatic improvement in his chest tightness. But as they were getting ready to go to the ER to get admitted, the patient coughed and then immediately developed sharp mid-sternal pain radiating to the anterior neck on the right side. There's no known triggers that that might have that the patient knows of that could have started this episode. No recent trauma, nausea, vomiting, diarrhea, or decreased appetite. And just to give a little bit of background on his asthma history, it's not very well controlled. He uses albuterol every other day for his chest tightness and short of breath, about once or twice. And then he uses his controller inhaler, which is an inhaled corticosteroid, about the same frequency, basically alternating every other day. And then he also uses albuterol treatments daily the morning prior to his prior to him going into work, and also after work and before he goes to bed. So patient gets admitted to the ED. He's tachycardic, but otherwise his vitals were stable. He was given albuterol and ipratropium dual nebulizer treatments 3 times. He was started on oral prednisone, and he was given IV ketorolac for discomfort.
Can you repeat the last part, please?
Sure. At the ED, he was tachycardic, but otherwise his vitals were stable. He was given serial albuterol and ipratropium treatments 3 times. He was also started on oral prednisone and was given IV ketorolac for discomfort. And at the ED, they also performed some imaging. Yeah, Jack?
Oh, I was just gonna the imaging.
Yeah, that will be later. And then he was he required a higher level of care, so he was transported to the hospital where I ultimately saw this patient. And that's everything for the HPI. Is it all right if I go into the southwest corner, or should we stop here?
I leave it up to you, Drew.
I think the southwest corner will give just a little bit more background, but it's not that much. Let's just put it in. So his major past history is notable for his asthma, which I had described before. And of note, he has been hospitalized about 3 times that we know of in the last several years. He has not had any surgeries. In terms of medications, he is on Symbicort, which is an inhaled corticosteroid, Singulair or Montelukast, Flonase, and both albuterol nebulizers and inhalers. And because this is a respiratory case, his immunizations are up to date. However, he has not received any COVID-19 immunizations or a flu shot. This patient was seen in the late summer. No pertinent family history, and the only allergies that he has are seasonal allergies. In terms of social history, he is currently a student. He does not smoke, does not drink, does not use any other recreational drugs. And to just round out in terms of his respiratory history, respiratory social history, he has no pets and there's no smoke exposure at his home. And I will leave it there for now.
All right. I'm seeing some fantastic reasoning flying in the chat here. Mikhail, maybe I can come to you to start off. You were one of the early discussants to think about this, the possibility of spontaneous pneumothorax here. Maybe I can come to you to share more about what you're thinking in terms of what historical features make that more likely.
All right, so good morning, everyone. So going off of the history, we have a young male complaining of shortness of breath and chest pain. So again, going back to the initial discussion we were having about whether this is lung related, chest related. The fact that he had his shortness of breath associated with pallor, as well as his decreased oxygen saturations on the pulse ox. And then he gives us a little classic history of he coughs and then there's worsening of the chest pain. Now, you have someone with clear respiratory disease who's now complaining of sharp chest pain post-coughing. I mean, we don't have the physical characteristics of the patient, but something like that, you always have to wonder in that thought process of whether this is a spontaneous pneumothorax. And then you look at so that aspect is why I kind of thought about the spontaneous pneumo. I mean, we would really like to get a more description of the patient themselves. But what I also wanted to find out more was, well, he did eventually give us, but his past medical history, because this is a very poorly compliant asthmatic who's maybe had recent ICU admission, who may have ended up on a ventilator, then that also puts him at risk of a pneumothorax as well. So that's where my mind was going when I was listening to history at first, basically.
Thank you so much. So really increase the pressures within the airway space, the sort of acute coughing event came there afterwards. And this background history of no lung disease potentially put this patient at risk for a respiratory or a pulmonary complication. I thought Anne-Marie also highlighted some really important factors to consider in evaluating a patient who has asthma, like when they are coming into the hospital. AMK, could I turn it over to you to share a little bit more about that?
So I've just been thinking about a patient who has a background of asthma. Some of the things I'm thinking about are risk factors for a severe exacerbation. There's a list of them online, but some of the factors include how many hospitalizations have there been? Has intubation ever been required? And so those are some of the things that I'd be evaluating, getting a really good background history of the asthma, of course, after they're medically stabilized and everything like that. And then also thinking about with asthma, you can get asthma plus syndromes. And so is there any kind of thing that tips me off that this might be more than just asthma? So is there eosinophilia? Have they been coughing up brown sputum? Any sensitivity to aspirin or ibuprofen or things like that? And then, taking a medication multiple times a day can be really difficult. The medications are unfortunately also really expensive. So have they actually been able to like what medications are they on, but are they actually able to take these medications, like either due to cost or access or just like a busy schedule or things like that. And then, you know, seeing how many times a day are they using albuterol, how many times a day or how many times at night are they waking up short of breath, things like that. And then also thinking about if this is just we talked about our concern for pneumothorax, things like that. But also thinking about what are the potential triggers? Is there an infection triggering it? Is there some sort of allergy or new exposure or lack of access to medications? So those are just kind of some of the things that go through my mind thinking about an asthma exacerbation if there isn't some other complicating factor in play.
I love it. Thank you so much, AMK, for that. I will just add to the discussion that has happened so far and share that one of the things that is striking to me is if we are grappling with a diagnosis such as a spontaneous pneumothorax that potentially happened hours ago or even a couple of days ago based on the patient's symptoms, I'm having a hard time rectifying that potential pathology with some of the clinical stability that we have here, right? Normally, I would expect if somebody had a untreated pneumothorax that went on for days and days like this, that there is at least some chance that the patient would be at risk for clinical decompensation. Now, many individuals can have a small pneumothorax that they tolerate quite well, but I'm sort of wondering is there a pneumothorax that just hasn't expanded in size yet, so there is maybe a small amount of air within the pleural space, but not necessarily something that has led to severe hypoxemia physiology being the other that we can see as a complication of a pneumothorax. Or did the air go somewhere else that is unlikely to affect the patient's pulmonary function in a significant way? Because when somebody has a pneumothorax, what happens there is that there is usually some sort of compromise in the pulmonary integrity and air makes its way into the pleural space. If air continues to make its way into the pleural space, patients will end up developing tension physiology, usually hemodynamic deterioration and shock. But if there's just a small amount that stays in that space, patients will maybe have some degree of respiratory distress, some degree of cough and lung irritation. I will say it is rare for me to take care of a young 18-year-old, but I am always struck by how well their body can compensate and tolerate severe underlying pathology. So I think as Mikhail mentioned to us, a pneumothorax is certainly a reasonable hypothesis. The other space that lung can go is not into the pleural space, but actually into the mediastinum. And there is something called pneumomediastinitis or pneumomediastinum that I see Mikhail mentioning here as well in the chat already. And the difference between that is that rather than air going into the pleural space, air will go into the mediastinal space. And so you may see air around some of the structures of the mediastinum, like around the heart, around the pericardium. And sometimes that air can actually leak into the subcutaneous space. So even before we get the chest x-ray, we may be able to palpate things like subcutaneous emphysema and crackles on the surface of the patient's skin because that air, rather than moving into the pleural space, has moved into the mediastinal and ultimately into the subcutaneous space as well. Pneumomediastinum or pneumomediastinum, unlike a pneumothorax, will not cause a significant amount of respiratory deterioration because that air is not building up next to the lung and limiting lung expansion or limiting venous return to the right side of the heart. So there's a chance that we may be dealing with a pneumothorax, but there's also a chance that we got lucky and that the vector of that air, when it left the lung, didn't go into the pleural space, but instead went into the mediastinal space. Again, risk factors for something like pneumomediastinum include many of the risk factors for pneumothorax, and particularly in patients who have underlying asthma, who may have hyperinflation, we could get a small amount of air translocating into the mediastinal space there. So I'd be very curious to see that. Right? It's something that will probably be picked up by X-ray or CT scan, but there is a chance that we may be able to get a sense of whether or not this is present just based off of the physical exam. The key differential diagnosis when you have pneumomediastinum is whether or not air has come not from the lungs, but from the esophagus. And so esophageal rupture is another important, or spontaneous esophageal rupture is an important diagnosis to consider in the presence of pneumomediastinum. mediastinum, which can be a devastating disease because of the fact that you basically have esophageal and food content leaking into the mediastinal space as well. So that I would say everybody has captured, I think, the line of thought brilliantly in terms of Anne-Marie thinking about the background, Mikhail helping us thinking about the risk factors for a pneumothorax. And I will just add that rather than the air going into the pleural space, it may have gone into the mediastinal space. But I'm very curious to hear from Drew where things unfold from here.
Okay, so I'm going to give you the physical exam on his arrival to our hospital. So vitals, temperature of 37 Celsius. Heart rate of 120. Blood pressure of 107/68. Resp rate of 20. And saturating 93% on 3 liters of nasal cannula. On exam, he was in acute respiratory distress. He was tachypnic with accessory muscle use. And just to go to his respiratory exam, he was speaking in, he was able to speak in full sentences, but he was very hurried and breathless throughout. In terms of his HENT exam, his head's normal, his ears were normal, his nose was normal, his mucous membranes were moist, and his oropharynx was clear. They did notice on the neck exam that on the right, they were able to appreciate some crepitus underneath the skin. Cardiovascular wise, he was tachycardic, but otherwise his rhythm was normal and was regular. And he had normal S1 and S2 with no murmurs, rubs, or gallops. Pulmonary wise, in addition to what I had said before, he also had expiratory wheezes throughout all lung fields, although his air entry was good otherwise, and there were no focal findings. In terms of his abdominal exam, it was flat, soft, non-tender, and bowel sounds were normal, and he had no hepatosplenomegaly. In terms of extremities / MSK, there was also tenderness with palpation of the mid-sternum. But even though there was crepitus that was noticed on the anterior side of the right neck, there was no pain. Skin was warm without any rashes, and his capillary refill was less than 2 seconds. And neurologically wise, he had no other focal deficits. And he had no cyanosis by the time we saw him. He was also, at that time, given morphine for pain, and he seemed much more comfortable and endorsed less shortness of breath. So I'm going to stop there for now. And then the next aliquot will reveal the final diagnosis.
So we have this sort of interesting update with the physical exam. I would say some, at least to me, some nerve-wracking vital signs to grapple with here, as well as the physical exam, and again, some response to initial therapy. So I saw some thoughts in the chat and sort of in terms of framing sort of this patient's vital signs as well as his clinical trajectory. Ramla, can I maybe come to you to talk a little bit about this idea of the impending silent chest that you had mentioned, and to share with the group a little bit more about sort of what that means and what the clinical significance of it is?
Sure. Are you able to hear me well? Okay,
Yeah,
great.
perfectly.
Yeah, this is a very great case. Thanks, Drew. You know, when somebody comes in with respiratory distress, you know, how in my head, I'm just thinking, okay, what am I worried about? What is going to kill them first? And what do I need to do to save their lives? And so with this silent chest, especially with asthmatics, you get worried about status asthmaticus, which is really a severe case of asthma. And when I say silent chest, is that the person gets so tired, they can't even like have the willpower to breathe. Literally, they just arrest. And so you got to be ready to intubate. If not, you might have been a bit late if you hear silent chest, and in a patient like this, I'm getting very concerned about him being literally in just a hypoxic. It looks like an acute hypoxic respiratory failure. And I would be so tempted to, really counsel the family and the patient that we may need to intubate before it's too late kind of thing. So that's what silent chest really is that there's just a loss of respiratory drive. The asthmatic cannot, they're just too tired. They can't breathe and you don't hear breath sounds. But at least here I see through the exam, some breath sounds are being heard, but still you don't want to be too late to intubate. So those are my thoughts.
Absolutely fantastic explanation, Ramla. Thank you so much for that. And then I see Catherine highlighting here the sort of some of the challenges in interpreting this patient's blood pressure. Catherine, can I maybe come to you to share a little bit more about what you were thinking when you saw the 107/68 blood pressure? And it's totally okay if you're not in a place.
Sorry, no, I'm here.
Great.
I was just trying to unmute. No, it's just that I know it is like he's young and that's probably expected for him, like his normal baseline. But I think on the other hospital it was a little bit higher, and I was wondering that also like with this heart rate and like stress level, it wouldn't be expected for him to have a little bit of like a higher blood pressure, because it's a little bit of bias too, because I got a case of a young man with spontaneous pneumothorax, very similar presentation, and then he was like borderline hypotensive, but he was young and people were like, okay, that's like just his normal baseline, but he was actually shocking because he got a spontaneous hemopneumothorax. So and it was so similar to this case, and I was wondering that might be also a hemopneumothorax case and the patient was losing blood, but I think that's not the case for here.
Amazing. Thank you, Catherine, for sharing your thoughts there. And I think really both Ramla and Catherine's point highlight the fact that in the early stages of evaluating a patient who's coming in with an acute asthma exacerbation and hypoxic respiratory failure, what our primary focus is not necessarily on making a definitive diagnosis of what the actual cause of this patient's symptoms are. It's managing the acute problems in front of us, whether that includes initial therapeutic intervention or gathering the data that we may need here, right? Ramla explained to us that really understanding the patient's respiratory exam and how it's evolving over the first minutes to hours in the emergency department is going to be incredibly helpful. Is the work of breathing changing? Are we seeing changes in the patient's breath sounds? Because any sort of small, if the patient's wheezes start to fade or go away, that actually isn't reassuring, as Ramla mentioned. That is going to be a sign that there is impending respiratory failure. If the patient's blood pressure starts to trickle down just a little bit, as Catherine is highlighting, right, in addition to the patient not being able to compensate from a pulmonary perspective, we may be seeing that the patient can't compensate from a hemodynamic perspective anymore. And both of those things, whether it's related to an asthma exacerbation or in this case, the consideration of a pneumothorax, are signs of impending severe clinical deterioration, either requiring intubation or something like an emergent emergent needle thoracentesis to remove any potential air that had built up in that space. And so what are we then doing as clinicians in this moment is we are not hemming and hawing over whether or not this is an asthma exacerbation or not, but we are really gathering the data that we need to make sure that we are going to manage this patient appropriately. That includes whether it's putting an ultrasound on the patient's chest or getting a chest x-ray right away to say, is there air in the pleural space, yes or no? And then also making sure that we're closely monitoring the trajectory of this patient's respiratory distress to make sure that things are going to be improving. It sounds like there was a very robust response to pain control and potentially anxiety control with the administration of morphine for pain, which may have also had an effect that in the process of mitigating the pain, hopefully decreases some of that sympathetic activation that may be contributing to the tachycardia, as well as kidney. So right now, response for us. It certainly does not preclude the need to get a very, very rapid answer to whether or not there has been a compromise of the pulmonary parenchyma that has led the air into the pleural space or air into the mediastinal space. The presence of crepitus on the neck, right, tells us that there is probably air that has made its way into the sub-Q space, and usually that is going through the mediastinum when it makes its way there. It does not tell us whether or not there is or is not a coexisting pneumothorax. You can certainly have air that gets into the space and the mediastinal space, and that could cause crepitus. And it also doesn't tell us for sure that that air has come from the lungs, because again, an esophageal problem, particularly for somebody who has taken high doses of glucocorticoids for a long period of time, is also something that's on the differential here. So where are we overall? We are monitoring for that Ramla highlight, and I think we're really anxious, at least I'm really anxious to know what exactly the patient's chest looks like, whether it's a pneumothorax, pneumomediastinum, neither, or potentially both here, because those findings are going to be very important management branch points for us as we think about getting this patient through this episode of shortness of breath and hypoxia. So I'll turn it back over to you, Drew, to bring us home for the case, and then I'm really excited to hear any final reflections from the group.
Yeah, so I just messaged you, Jack. I will need to share my screen in order to show you guys the chest x-ray.
I'll make you a co-host right now.
Thank you.
Okay, yeah, I'm gonna start sharing.
That's it right there. And the CT showed pretty much the same thing. So there's a little bit of air right about here in the mediastinum. So yeah, you guys nailed it in one. The final diagnosis was an asthma exacerbation complicated by pneumomediastinum. Do we have a previous chest x-ray? I would have to take a look back, but as far as we know, this was the first time that this has happened. And also in the chest x-ray, there's no evidence of pneumothorax either. So we were confident in calling this just an asthma exacerbation with pneumomediastinum. All right. And just to give a little bit of just like closure to the case, he was given he was continued on oral steroids, continued on albuterol and albuterol ipratropium nebulizer. His Symbicort, his Flonase is Singulair, and his respiratory status ultimately improved, and then he became stable on room air. And ultimately, the cause of the mediastinum is most likely due to the fact that he had a severe coughing episode prior to his going to the ER. And so we ultimately did asthma education. He ultimately followed up with his allergist rather than primary care, since he doesn't have a PCP at this time. And so, yeah, that was this case, and a pretty interesting one, because this patient actually came to us on our night shift, and actually I was cross covering at the time, and it was kind of a scary case where we were thinking, oh crap, is this guy going to have to go to the ICU because of how bad he looked? And oh, by the way, for this patient, we also strongly recommended that he get his COVID and flu shots. And he also got his pneumonia vaccine as well, pneumococcal vaccine. So yeah.
Awesome.
Thank you so much, Drew. I will say I'm very relieved that this is the direction that this case went, because pneumomediastinum, while terrifying, if if there is going to be a compromise in the pulmonary parenchyma that leads to air leaking out of the lungs, I'm very relieved that this happened to go into the mediastinum in the sub-Q space rather than the pleural space for this patient, because that could have been much, much worse. And I think, yeah, thank you so much for bringing this case to us. This was a really nice example of a complication of underlying asthma, as well as of some of these coughing episodes, with a really nice physiologic explanation here. But also, I would just also want to highlight a really, really sad case that this is such a young patient who is having such frequent hospital admissions, potentially preventable hospital admissions. I'm struck by potential challenges in access to primary care here, that and just really hope that with time for this patient being able to live a young adult life without frequent hospital admissions, that there is that his care team and his family are able to reduce the total number of hospitalizations, because this is always sad to see in any patient, but particularly somebody so young like this. I'm curious if there's any reflections from the group, just in terms of this case specifically, any other elements of the history or the case that jumped out to you. And if there aren't, we can go ahead and turn it over to Gabriel for the teaching points here, but I want to leave it open for the group to share any reflections going forward before we wrap up.
Just wanted to also highlight, so I know it wasn't in this case, but this is a young male who seems to have some amount of stress as well. So I was also worried about ingestion, because at least within my population, it's not uncommon for them to have ingestion of caustic agents, which may not necessarily show up in the oral cavity, but maybe it causes an esophageal perforation then in that case. So like, I was kind of looking out in the history for something like that as well, because they could also still have respiratory like symptoms, but they could also have the pain in chest, shortness of breath, and the subcutaneous emphysema, like you had also highlighted earlier. So it's just something that I was also looking out for, just based off of my personal history and population wise.
Thank you so much for highlighting that, Mikhail. It's a really important point that I know Anne Marie also mentioned in the chat earlier on, around dyspnea and chest pain. We oftentimes think cardiopulmonary disease, like we talked about early on, but really making sure to not forget about the esophagus there, particularly because ingestion can irritate the esophagus, and then ultimately the pathology can make their way into the pulmonary space or into the mediastinum as well. So yeah, I thank you so much for highlighting that. Drew, thank you again for an absolutely fantastic case, super educational here, and yeah, really glad that the patient ultimately did well, that you had a chance to get to care for him, and that we are lucky enough to get to learn from the case here. Gabriel, I'm going to turn it over to you, and would love to have you take us home with teaching points. But thank you again, everybody, for joining today.
Thank you so much, Drew, for the case, and Jack or the CP Solvers family for the amazing discussions. So for the teaching points around leukemia, a patient with a previous asthma hospitalizations giving these teaching points of an asthma case. So at first we were approaching the chest pain, so we have to remember that 4+2+2 pneumonic. So we have to inquire about acute coronary syndrome or aortic dissection, tamponade, Takotsubo, pulmonary embolism, pneumothorax rupture, esophageal rupture, or impaction, because they are the most morbid complication of a chest pain. The patient came to the ED because of dyspnea plus chest pain. So those symptoms prioritize if a cardiac or a pulmonary system problem. So then Jack was wondering about how to narrow our differential. So we have to look for associated symptoms. For example, a volume overload of the patient should prioritize a cardiac system complication. And also the age is very important, because age points away of acute coronary syndrome and Takotsubo. So then with vitals, more history, we were trying to solve this puzzle. So in a patient with poor controlled asthma, Anne-Marie told us about we have to think about asthma plus syndrome. And we also want to look for risk factors for hospitalization because they will be very important in the treatment, and also look for triggers such as respiratory infections, medications. One of the most common is aspirin-induced asthma, and also complications of the asthma, such as pneumomediastinitis, pneumothorax, and we also want to inquire about the access to medications. Also, we were trying to remember if this could be something else, how the patient got the diagnosis of asthma. So there are some differential of the disease, such as allergic rhinitis, GERD, bronchiolitis, pulmonary ciliary dyskinesia, cystic fibrosis, or bronchomalacia. Those diseases are kind of rare and they're diagnosed in a very younger age. So they are less likely, but we have to keep in mind if this could be something else. And also Jack told us about that young adults can easily compensate hemodynamically, so we want to be careful in evaluating the vitals. And also someone in the chat mentioning a highly important fact that we also want to look for red flags of a severe asthma crisis. And what are them? They are silent chest, cyanosis, altered status, a paradoxical pulse, hypercapnia, and acidosis. Because for a production of hypercapnia in a patient with asthma, the forced expiratory volume must be very low for producing this symptom. And also for the workup, we want to do a follow-ups of the vitals, how the patient is doing hemodynamically and how he is doing the respiratory function. And we also want to do a chest X-ray for ruling out these complications that we were talking about, such as mediastinitis and pneumothorax. And then for solving, finishing solving the puzzle, the patient had a crepitus that associated with respiratory wheezing in a patient with a past medical history of poor control asthma. The final diagnosis was an spontaneous mediastinum plus an asthma exacerbation. So thank you so much, guys, for plugging in. See you tomorrow on Neuro VMR.
Bye, take care.